Hello everybody. We'll give it another minute just as people continue to join, and then we'll start the session from that point. Thank you very much for your patience. Okay, everybody, we'll make a start. So, good evening and welcome to this EMIS live session, Collaborative Approaches to the New Normal. I'd like to welcome you. My name's Ian Bailey. I'm District Nurse and Senior Clinical Director at EMIS Health, and I have the privilege this afternoon to lead this session for you. Before I go into the session, I'd just like to introduce colleagues that will be taking part today. First of all, I've got Dr. Nick Bucks. Nick's a GP and clinical design consultant for EMIS Health. Dr. Mike Hearn. Mike is GP and Managing Director of Taurus Healthcare. And finally, James Harley. James is the IT Project Manager for Taurus Healthcare. I'll introduce them more as the session goes on, and you'll also get an opportunity to ask questions of them all towards the end. So I'd just like to encourage you at this point to use the question and answer functionality whilst the presentations are occurring, and I'll make sure that at the end your questions are either answered by the panel, or if for any reason we run out of time, I will make sure that you get answers to your questions following the session. So for the session, it's fair to say I'm probably preaching to the converted in terms of the audience today to say that COVID-19 has brought challenges.
Ian, you've muted yourself.
Sorry, thank you, Liz. Don't know how that's happened. So we'll use this session to consider what's been learned from responses so far to COVID and how we can take the learning and apply that to enable us to work more efficiently in the future. Now, one of the challenges faced in returning to the new normal is addressing what people are known to be calling now as the void in care. And that's emerged for such things as reduced cancer referrals, reduced uptake of vaccination and immunisations, and particularly gaps in planned long-term condition management. I'm pleased, therefore, to introduce two speakers today who share their experience of responding to COVID and how it's changed practice both for now and into the future, and then also look at how technology can support new ways of working. First to present today is Dr. Mike Hearn, Managing Director, as I described, at Taurus Healthcare. Mike's a GP in Herefordshire and plays an active role in setting up and continuing to develop Taurus Healthcare, which represents GP practices, as well as delivering services such as out of hours, improved access and training hubs. Mike's going to share his experiences of the Federation's response to COVID and the learning that they're now taking into the new normal. At that point, Mike, thank you very much. I'll hand over to you.
Thanks, Ian. Good evening, everyone. So yes, my name is Mike, and as I always introduce myself as a GP first and foremost, but seem to have found myself in the managing director position for the Federation, and James Harley obviously is the expert at putting a lot of this together, which we'll talk through. Just a brief intro, really, a bit of background first of all on how we got to where we are, and indeed therefore taking you through then the COVID response. I think the key elements for Taurus is actually we represent and work with all practices in Herefordshire. We're very lucky to have that position, so it gives us a really strong position of working with practices to look at a general practice-wide resource. Next slide, please. So in terms of the background, you know, clearly we've had to look at GP forward view. We've looked at something called primary care home, which some of you will be familiar with, and of course now it's the latest is primary care networks. And we see this really as a kind of bringing together of the of all the different elements, of the at scale elements, to look at resilience, but also to try and centre on the kind of patient care delivered through technologies. And clearly COVID has accelerated that hugely. Obviously, in terms of Herefordshire, we're lucky in that we've got one CCG, one local authority, one mental health trust, and one acute and community trust. So it's working with one GP federation has played a key part, I guess, in those relationships and developments. And we're also lucky to have all practices on EMIS, as well as the community and hospice teams also just started out on their journey with EMIS. And I'll talk a little bit more about the management support and wraparound. Next slide, please. So just in terms of Taurus's role, Taurus has got a mandate to represent all practices in Herefordshire in the kind of various discussions in the developing integrated care systems. And as part of the networks, we kind of we represent we're the nominated provider for 4 of the PCNs. The 5th one is a super practice in itself, but it very much aligns with us so that we can provide, again, that joined up response, working with providers across the STP in Worcestershire. Next slide, please. So Taurus really here for 3 things, really, and this is what we describe our function, really. So first being the federation, where we look at supporting the practices, underpinning some of the resilience in doing things like recruitment service, the business intelligence, which has played a key role during COVID, and various other things like quality assurance. We are a direct provider, but we don't see ourselves as being kind of your usual provider that comes in to bid for contracts. We look at actually providing effectively the 6th network support to the practices. So GP out of hours, improved access are the main contracts, but actually we look at delivering any of the contracts that need to be considered at scale. And clearly the PCN management team that we support all practices has played a key role in the rollout and the rapid delivery of any COVID response. And then the final thing, of course, is the strategic leadership. Having that kind of docking point to work with other providers, again, has played a key role for the CCG to know to talk to, but also for other providers, the acute trust in particular. And again, that has accelerated our collective response. Next slide, please. So during the kind of COVID response, these are the key things that we kind of agreed at the start of our journey. Clearly looking at that single team. But one of the things to stress, as I'll stress throughout the talk, is an approach to 24/7 general practice. So often we consider now that general practice to be the in-hours element, but actually it's really important that we join it up across that 24 hours. And as I've talked before, we looked at working with other partners, having a pragmatic approach to that support. And obviously learning from elsewhere, as we all did. And I'm sure if some of you are on the national WhatsApp groups, there's lots of learning, almost too much at times, but very helpful as well. So brought that into the local system. Next slide, please. So 3 key steps really, and that was really to deliver a Herefordshire Clinical Director Forum, which dovetailed with the primary care network response. With the appropriate representation on the strategic groups, which bring some of this together. I'll talk a little bit more about the hubs that we developed. So we call them amber and super green, but I'm sure we all call them different colours. But obviously that was a key part of the response. And of course, as I said, the 6th primary care network, which is not just out of hours, but we also delivered the COVID management service, which has been a key element. And providing that wraparound support. And again, key elements of the wraparound support were not just the management, but the governance, the digital approach, looking at education and trying to align the workforce across all partners, but particularly across our PCN. Next slide, please. So in terms of the kind of our learning, really, I think this summarises what we have reflected on. I think particularly, the elements of general practice it being clinically led has been a huge part of it. And obviously the agility of all the response has also played a key role. And as I said before, some of the areas of joining this up, they've all played a part of this. So the education, we've had weekly educational events with all practices, which is often been an update on COVID, as well as a discussion with secondary care colleagues at times, sometimes a panel discussion about our collective response. and that has helped the communication hugely. And we've had a TeamNet page which has basically been a resource where all these various guidance has been found, where they can contact and find out what the latest guidance is. But the box on the left hand side is what really is going to talk about a little bit more today, the digital elements of this, and how we've kind of supported the various elements to deliver the COVID response. Next slide, please. So really, these are the key elements of the response. So the COVID management service was something which in a lot of areas went to the out of hours provider, and that's obviously how we got involved in that. But one of the key things for us was providing a virtual GP service, and in particular using Taurus EMIS system, which had access through data sharing, which you'd already set up to the whole patient record for all the patients in Herefordshire, which is the same system we had in place for the improved access previously. But we set up a virtual reception and a virtual GP service with use of soft phones through the IT systems, and again dovetailed, I guess, with the in-hours general practice, and tried to support the practices where they needed it. And sometimes we found even a recent outbreak at a farm, which you may have read about on BBC News. We found that actually that's been really a helpful resource. The practices were inundated already with their capacity, so it's been a helpful thing to take forward. We also set up in a similar way a super green service. So we all had the problems associated with shielded patients, but for our approach actually was to look at a clinic dedicated to shielded, as well as having a visiting service, again provided on one EMIS system, and again provided working with an integrated way with our district nurse colleagues to support the delivery of that. So those are the county-wide bits. But on a PCN level, we looked at the kind of amber hub, as we called it, and amber visiting. But these were the kind of areas where you dealt with people who were at risk of COVID, and again dealt with on one EMIS system, which was enabled. We were able to do cross-organisational tasks using the EMIS system, which was really, again, a positive innovation which we hadn't used before pre-COVID. And that matrix management approach to the management and governance and the BI. So we were able to look at activity across general practice. We were able to look at matrix management approach to ensure that all parties involved in those amber hubs in particular, we knew who the clinical management was involved in that, and we knew where the operational elements sat, so that we were clear and actually had CQC approval to make sure that we were delivering this in a joined up way, which was consistent with ongoing quality service. And of course, we linked it in with 24/7 general practice, and in particular using EMIS Web. One of the key things, of course, as well was EPS, and the EPS for our module of EMIS was set up during this time of COVID, and made a big difference, because prior to COVID we certainly didn't have this set up. And now we've been able to not only introduce it using EPS and EMIS within those hub services, but we've now also introduced it into out of hours. So we've now got 24/7 general practice on EMIS across the whole county in terms of general practice, which has been a real positive. Next slide, please. So I guess the question is then, you think about, well, to reflect on all of this, how do we kind of take forward some of the learning? How do we take forward and think about what we could do in the future? So the key elements that we've thought about using some of those responses have already been taking place. So we've already been working with our partners at looking at a transformation board and having a clinical forum where we get partners together to discuss some of the issues to ensure that they are clinically led at the start of a proposal. Too often clinical input has often been a tick box exercise afterwards, so we found doing this now at the start of the journey has been extremely helpful. And these are key elements I've written down here that would help give us the kind of some specifics, I guess, at taking things forward. Clearly, we all have the challenges of now, how do we deliver all the integrated work that we need to across primary care networks? And there's a real big challenge, I think, in terms of how we do that in an integrated way. So we have the challenge not only of how does general practice work together across a number of practices, but also how do we work together with colleagues in an integrated fashion across district nursing, social care, public health, and into local communities. So the EMIS platform is going to play a big role in us for that. And certainly the learning that we've had already using the Amber hubs, using the One EMIS system has played a key part in what we will do next. So already we're having conversations about extended hours and thinking about actually can we do that in a joined up way, and actually can we look at thinking about how we kind of develop our conversations with the community, with the acute trust. So some of the things I've highlighted on here, the first one was about MDT working, clearly a key part of how we work together, but actually that virtual response using the One EMIS system, things like cross-organisational tasks, really enable that joint working. And I'm a true believer in that MDT working isn't about an MDT meeting, it is about how you respond and work together as a team. And I think that's very challenging when you look at working across a PCN. So that's a key element of what we want to cement moving forward in terms of the MDT. Care homes is the second one I've mentioned on there, and obviously with care homes we're particularly looking at joining up what happens in secondary on the weekends, as well as what happens obviously Monday to Friday. So obviously from the PCN point of view, we have the expectations that there will be various care home leads and joining up how we deliver some of those services. But actually we need to also join them up with what goes on with out of hours and what goes on with the weekend. So we have a service in place at a weekend, and we also have a kind of more of a joined up approach now with our community services, and developing that further with social care colleagues and direct response to care homes, so providing them with some educational resource as well. The 2-hour community response is a big thing in terms of delivering at a PCN level, and the expectation is for a lot of acute trusts or community trusts to be delivering this, but actually we recognise that we need medical support for that, and again are hoping to work up that using the similar model to ensure that there is some virtual medical support to the community teams, which doesn't always rely on the GP, a home GP who clearly knows the patient best, but actually sometimes is too busy. So this is just about adding capacity to that and working with our general practice colleagues. Meds management, I mentioned there because clearly we all get meds management questions, patients every day asking us to look at their to some kind of medical query, and actually how we use pharmacists in particular could actually be done in different ways. So we don't necessarily need to do it at every practice. We could do it collectively at a PCN. We could do it collectively at a county level. And one of the key things for all of this, and as I've said earlier down at the bottom, is how we join up the appointment system. Something simple like an appointment system can be very complex. So using the EMIS system has been really helpful so that people can actually do a cross-organisational appointment book and therefore can use it for a number of things such as meds management, but a number of these activities. The community hubs I mentioned in terms of how we integrate with the acute hospital, it's simply because we've all noticed that the outpatients now has become predominantly remote. Never thought we'd see that, but it has been. But obviously now there is an increased need now for things like phlebotomy, which is not being done at the acute. And the question is where will that be done? And obviously concern going on nationally is that that's been pushed out to GP practice colleagues. So we're actually having quite positive discussions with our acute trust about how we can identify the demand for such service, and therefore how can we integrate it with the general practice phlebotomy, as an example, into to joining up some of our resources. So clearly key elements for this is how we join, is what system we use, but obviously is understanding the principles that sit behind this may well sit very well with lots of other services moving forward. Long-term conditions obviously will play a big part now. So we look at QOF, we look at all the other areas that of QOF that we need to deliver. We need to deliver collectively, and already we're having discussions about how we can do some of that work remotely and how we can do some of that work collectively. I know there's lots of talks about things like group consultations, using integrated ways of delivering much more support for those long-term conditions. and that needs to involve both from the voluntary sector right up to the acute. And often we look at these things in silos. So I know we're going to talk more about long-term conditions in a second, but actually how we approach that is going to be a key element of, I think, of how we successfully promote a kind of more upstream approach to the kind of management of long-term conditions, which plays a big part. Ian, I was going to answer the couple of questions I can see in the chat box. I don't know if you want me to answer those now, but clearly I can do that now or later. But that was all I had to say. I think generally on the kind of COVID response so far. I think I can pick up questions if you like at the end. So happy to take this.
That's great. That's great. Thanks very much, Mike. We'll save the questions to the Q&A panel at the end. Give you an opportunity to take a breath.
Thanks.
Okay, so fantastic presentation there, Mike, and you're right, we've had some questions coming through already, so undoubtedly has provoked some thought within the audience, which is fantastic. Thank you. Just a reminder to the audience that if you do want to ask questions, please put them through and we'll bring those in at the Q&A panel at the end. I'd now like to introduce Dr. Nick Brooks. Nick's a GP in the Midlands and is also a colleague from EMIS. He's a clinical design consultant. And Nick's going to talk to us about the developments that he's been leading on within EMIS around supporting long-term condition management, both to support healthcare services to address the void that we described earlier, and also to look at a greater efficiency in managing such conditions in the future. Nick, thank you very much.
Thank you, Ian. Well, as Ian's given the introduction, I'm a GP and work as a clinical development consultant for EMIS Web, and also as a training programme director for Health Education England and a medical author. But I think of them really as one role with a shared aim, which is helping patients to get excellent healthcare. And that's what we've been concentrating on at EMIS by using our smart technologies to try and improve the care for patients with long-term conditions. Can I have the next slide, please? So we started off with a set of aims. We wanted to be able to identify the patients who are most in need of care, to group them by condition and to stratify them so that we could identify those with the most need, including those who are perhaps missing care, those who are being shielded because of the COVID crisis. And that's where our EMIS X analytics platform comes in to provide us with the ability to identify, cohort, risk stratify and visualize that information in more complex ways with better insights than we've been able to do with our current software. Of course, we want to support clinicians who have had a very difficult time and have mounting issues with capacity. We want to be able to continue to provide high quality patient-centered care, and so we want to help clinicians by providing information that supports decision making, what we call intelligent contextual support. Crucially, we're not trying to replace clinical judgment, we're trying to work with clinical judgment by providing the data that's needed to help manage the complexity and to better inform clinical judgments that are made. It's really important to us that the systems are accurate and safe, and both accurate and safe to use, but improve the accuracy and safety for our patients. So the systems help to pull data from record, ensuring that the relevant data is presented to the user. When you have huge records, it's difficult to manually search through and identify all of the relevant data. So we can bring that data through to the clinician and to flag situations that present high clinical risk. Imagine, for example, the patient is identified with an irregular pulse and has no condition that would be consistent with that. That's presented as a high clinical risk, potentially perhaps a new diagnosis of atrial fibrillation or other arrhythmia. And we want this the system to be evidence-led. An LTC manager and its associated systems provides focused guidance relevant to the patient in front of you, drawn from the nationally recognised evidence sources. For example, National Institute of Clinical Excellence, from drug summary of product characteristics, from the BNF, from manufacturer's dosing. And where a patient is showing signs of poor control, the intelligent contextual support is able to provide the next recommended step from the National Institute of Clinical Excellence guidance or other relevant evidence sources, along with information that might influence that decision, whether that be blood pressure information or information from blood test results that will be relevant to what you're doing next. We want the situation to be quick and easy to use, the system to be quick and easy to use, because it's so important. I'm a GP and I find that capacity is an issue. So I need something that's quick, that reduces the time I need to assess and manage a patient, that helps me to quickly document what I need to document. And this is what we're trying to do with Long-Term Condition Manager by displaying the relevant information in a clear and logical interface by using red and green indicators to call out good areas of control and poor areas of control to help provide that documentation, and by offering support such as prescription management support. And we want this system to be both leveraging skill mix and reducing cost. So we recognise that primary care teams are diverse and that Long-Term Condition Manager needs to be flexible for all clinical teams. And so it's usable by healthcare assistants, physician's assistants, pharmacists, nurses, doctors, paramedics. So by enabling users such as healthcare assistants, paramedics, physician's assistants to support the collection of information and giving advice supported by the clinical system, we allow the most effective use of resources. So let's move on to the next slide, which shows us a bit about the pathway. So what we're looking at here is the pathway to care. So we start with the blue box in the top left that's labelled analytics. And this is the pathway that we've looked at going through to improve care. We need to use good quality analytics to help us identify patients most in need, those missing care through shielding, those with the highest need due to risk stratification. And using the EMIS-X analytics platform, we can now stratify risk in new ways and more complex ways that we couldn't do before, and I can show you that on some subsequent slides. Once we've identified the patients, we move on to proactive patient contact, the orange box, where we're contacting the patient, bringing them for a clinical assessment. Now that might be bringing them through contacts remotely through video consulting or other methods of contacting the patient to collect data, and then assessing the outcome using the smart technologies that we've been developing to then help to improve clinical outcome. And then we go around again, assessing how is the control once we've been through that circle, and on until we achieve the excellence that we're after. So let's look at two measures of health outcomes, which is QOF and best practice outcome. So we've divided our guidance into QOF, which is a subset of best practice that comes from NICE, and we've also looked at wider information that indicates best practice and supports good care taken from other sources of NICE guidance. And those are two droplets that form and go into our ocean of health outcomes. So what we've done in our EMIS-X analytics is reported on risk stratification, both of QOF, but also of best practice. And let's look at some indicators of that to give that some specific examples. So let's have a look at the next slide here. And what it shows is, for example, in hypertension, QOF is interested in looking at two areas. It wants to know if the blood pressure is well controlled in the over 80s and the blood pressure is well controlled in the under 80s. But we know that best practice for people with high blood pressure is a lot more than just that. So we want to give a deeper insight into the patient, understanding the patient needs. And the EMIS-X analytics allows you to do that across populations, across your GP practice, across your primary care network, across whatever combination of services you want to use. You can analyse much greater detail about patient control. For example, if we wanted to look at progress to non-HDL target, we can do that now using the complex queries we can manage and enter through our EMIS-X Analytics Explorer platform. So before, whereas QOF will give you information about two areas, we can now give you information about another 9 areas, and you can get much better insight into how we're promoting clinical excellence for our patients. So I'm just going to move on to the next slide here, and that will show you our EMIS X Explorer. This is just an example of EMIS X Explorer, an instance of EMIS X Explorer, and we can enter queries in SQL that allows us to build up very complex queries to look at the data that we have for patients and patient groups, and that will give us information back in a way that we can visualize much more beautifully and meaningfully. So if we look at the next slide, it shows an output from EMIS X Analytics. This isn't an example of a long-term condition manager output, but gives you an example of how we can represent graphically information to better stratify and understand the level of quality of care and support that we're able to provide to our groups, whether that's in our own practice or whether that's across practices in a primary care network or in a CCG. So EMIS X Analytics is going to help us to identify the cohorts, visualize them, identify risk better than we could do before. And let's look at how the intelligent contextual support is going to help us better manage those patients. So if we go to the next slide here, here's an example of an intelligent contextual support example for a patient with high blood pressure. It's using that red warning of the blood pressure being not controlled for this patient. So we're drawn to this, and for those who have a red-green colour blindness, there's an exclamation mark, an additional visual cue, and the blood pressure's not well controlled. So the LTC manager has looked at the medication that the patient is on and has identified from that what the next guidance step is using the NICE guidance. It's then pulled that out and displayed it in front of you so that you can take that into consideration when you're making your clinical judgment as to what the next step of treatment is. So that will help to nudge us towards the NICE management if it's appropriate. But of course, the clinician knows the patient, knows their background, knows their lifestyle, things that the computer could not possibly know. And so we're getting the best from the computer and the best from the clinical support to help them rapidly to make a decision with the patient that best fits them, that is safe and that will provide excellent healthcare. So let's look at another example of intelligent contextual support in the next slide. In this slide, we're looking at a patient who has been identified as suitable for using an ACE inhibitor and is on an ACE inhibitor, but their dose may not be optimized. So it's bringing out the relevant NICE guidance about optimizing the dose of ACE inhibitors, along with other evidence about target doses. It's giving you the information of where that's come from so that you know the quality of the evidence to inform your clinical judgment. It's also giving you the relevant contextual information you might need. So to prescribe a dose of ramipril, I need to know, what is the next dose? So what are they on now? So it's giving me that information. Is it safe because of their kidney function to give them an increased dose? It's telling me what their kidney function is. Okay, will their blood pressure tolerate their dose being increased? So I've got the blood pressure information. I don't have to search for those different bits of information that I would need to help make a clinical judgment about this patient. And if they can't tolerate it because they've got maximum tolerated therapy, I can just click on the drop down and document that there. So it's making documentation quick. It's helping to inform the clinical decision, making it safe by giving you making it safer by helping giving you the relevant guidance about treatment to help improve that promotion of clinical excellence in patients and improve health outcomes. So these are just a small snippet of the intelligent contextual support that's provided within LTC Manager. Let's look at the next slide then, which is a summary really of what we've been talking about. And that is that we want a system that will support the clinician and support the patient, that will improve accuracy and provide high quality patient-centred care by supporting the clinician who best knows the patient with the information rapidly pulled out from the record. That it does that with the best evidence we have by providing guidance from nationally recognised sources such as NICE, the BNF, Product of Summary Characteristics, a system that's quick and easy to use, that can be driven by healthcare assistants for collection of data, leveraging the skill mix and leaving the clinical review stages to clinicians and supporting them with that review. A system that with EMIS-X analytics will give us better insights into our population and better enable us to care for them. And that's really what our long-term condition manager work is all about.
Nick, thank you very much. Another great presentation. Okay, we're going to take the opportunity now to move to our question and answer session. We've had a number of questions that have come in during the presentation, so that's great. Thank you very much. There's still the opportunity to use the Q&A functionality as I've described earlier to ask questions as we carry on. I'm going to take the opportunity now to introduce James as well. You hopefully see all four of us on the screen now. So James, as I described earlier, is the IT project manager at Taurus Healthcare. James has considerable experience and background in successfully delivering digital and technology projects across all healthcare domains. So hopefully James will be able to take any tricky technical questions as well that the audience might have. So lovely. Nick, I'm going to give you an opportunity to grab a breather and a quick drink after that presentation. So I'm going to move to Mike. Mike, so first question is that your last slide was titled "What's Next?" and you discussed ongoing service developments, but could you describe what you've learned about collaboration, shared resources, communication and culture, and what you'll take forwards post-COVID? Great question.
Thank you. Yeah, I think one of the key things really with any kind of change, if we look at the core of general practice, what works well about general practice is it's clinically led, it is agile, and there's a degree of ownership, autonomy, and the particular focus, of course, is around kind of how you work. The culture of general practice is absolutely central to a good quality delivery of care. And working as a whole team, so everyone plays a part, from reception to the nurses to who's doing the EMIS templates, whoever it may be, we're all playing a key part. So the challenge, I think, really is looking at that model and how you look at that collaboratively. So the particular thing that we've kind of focused on and hope are taking forward is involving frontline early on, so that they feel that there's an element of ownership, there's an element of being clinically led, and that management are therefore supporting that function rather than necessarily about dictating it, which I think is a difficult balance. But that engagement early on is absolutely crucial to get right, and I guess has played a part in not only the start of the services that we did during COVID and before that, but also how we're working with partners. And as part of that clinical forum I mentioned is all about that, trying to develop that culture really of understanding a problem and being able to come at that together in a joined up way. So some of the challenge that we provide each other when we're talking with the acute trust or mental health is really, have we considered all elements of a pathway? For instance, when we're looking at that change, we often don't think too much about prevention. And I think general practice could generally do that better. But actually mental health, we quite often don't think about mental health in some of the long-term condition stuff. It's particularly at the acute. So that's one of the challenges we also consider, as well as thinking about that generalist review. So it's and I think once you've come up with that solution and working together, one of the ideal outputs really is you're thinking actually, rather than thinking about a service in silos, and layering on service, it is actually how you're thinking about using the best of your resources, putting them together and actually working as a team. And I think that's something that has happened during COVID because it had to. And I think actually how we hold on to that is going to be crucial to the development of any successful integrated care system.
Fantastic, thanks Mike. Absolutely some crucial points there, and you're right, just with your latter point, undoubtedly I hear lots and lots about the fact that COVID has really pushed the boundaries of collaboration and I guess even broken down what perhaps others have seen as traditional boundaries, which it's good to hear that you're taking forward. So that's fantastic. Very closely linked to that, Mike, but perhaps a shorter answer for you. A question around how many patients and how many GPs have you got across Herefordshire? Clearly somebody that likes the data.
That's about 190,000 patients. GPs wise, we're just under 100 GPs across all the practices, but that doesn't necessarily include the locum GPs or the out of hours. So those are the people who are based in practices. So short and sweet answer too. Lovely,
that's great. Thanks very much, Mike. Okay, sticking with Taurus, James, we've got one for you. Question says, we've heard a lot about the tourist experience from a clinical and patient perspective, but I wonder if you could tell us more about what's made it possible from a technology perspective.
Yeah, absolutely. Good afternoon, everybody. So obviously technology is key to enabling the services and functions that in Mike's slides, and the main ones I've identified to enable a truly location agnostic GP service is firstly remote access to the HSCN network. So to enable clinicians to have access to EMIS, NHS spine services, mainly smart card, EPS, and access to the PDS, which is essential. Enabling data sharing, so access to the entire population of the Herefordshire patients' records within a single instance of EMIS. We're using EMIS clinical services. Access to telephony and video technology, and integration with other clinical systems. And as Mike mentioned, a big win for us back in at the beginning of March was the enabling of EPS within EMIS Web Clinical Services. And this, combined with the data sharing agreements we already had across the county, essentially means a clinician can complete an electronic prescription to any patient registered at a GP surgery across Herefordshire to their nominated pharmacy, and that's all from a single instance of EMIS. So that's been absolutely fantastic. Another huge benefit was the development of soft phone technology from our telephony provider, Exon Surgery Connect. So this now means that clinicians can make secure calls from any device connected to the internet using a modern browser. All the calls are recorded, and if necessary can be converted to a video with a single click of a button without breaking the link with the patient. So essentially it's a voice call which can be converted to a video consultation in a single click. And because this is an extension of the on-site telephony system, it means the clinician incurs no cost to themselves. The number can be hidden from the patient or set up to display a service number or a group number. And the system also enables tourists to set up a call centre as well, where a number of admin staff and clinicians can access and manage the service from any location. And I talked earlier about integration. Another thing that's been key for us is GP Connect. So GP Connect now enables EMIS to integrate with other clinical systems, and what's key here is one-on-one direct booking. So with GP Connect now enabled in clinical services, it has now opened up access to 111 and out of hours to be able to directly book into our appointment books in clinical services. And so eventually we'll be able to share our care records back into their clinical system, Adastra, so they can have a view of that as well.
Fantastic, thanks James, a great answer, and well done for explaining it without using too much technical jargon as well for those of us that don't understand.
Thank you.
Well done. Thank you. We're going to stick, we've got one more question at the moment for you, Mike, and it's a great one. Was there one significant technical or NHS policy change that enabled you to deliver services to your patient populations in the early days of the pandemic? So not just about the pandemic itself, is there policy change or technical change?
Yeah, I know. I've been contemplating this one since it's been up there because it's a good question. I think one of the big things that we noticed was some of the local ownership. I think was the NHS policy change, particularly, was allowing local CCGs to rapidly make some of the decisions. And what is interesting for us as a federation is, even though we kind of directly work with practices directly. We actually directly run one practice. We're still seen by the NHS almost like we're a kind of separate, completely separate being. To how, you know, getting access to the same services as our general practice, we end up being treated differently. So I guess one of the key things for us was the different approach that the CCG were able to take in working with the Federation, because actually they were working with general practice, and that was the big thing that changed. And actually our CCG were fantastic. They were really supportive. They rapidly rolled out a lot of the hardware and the software that went with it, really. And I think that for me was the biggest change, really, was that kind of shift in terms of how we consider let's just do the right thing. And the local CCG were really supportive with that. And I think the NHS policy really helped support that. Whether we'll stay in that world remains to be seen.
We can only hope, Mike, but absolutely, I think one of the loudest messages that's come out of COVID and its response so far has been about that empowerment and almost I guess a reduction in some ways of national policy and diktat. So yeah, let's hope that we absolutely do remain so. Okay, Nick, hope you've had opportunity to rest now, because we've got quite a few questions coming for you. So first one, what's the difference with long-term condition manager compared to what you've got now in EMIS Web?
Okay, so I think the point to start with is the starting point. So in terms of how we identify patients and risk stratify them, at the moment there are limitations if we want to look at data in a practice or across a group of practices like a primary care network or a CCG. The ability to look across those combined populations is more limited than it will be in the EMIS-X analytics option. It means it's much more easy to bring up data sets across those populations, and it also means that we can analyze those data sets more meaningfully. The ability to create the complex queries that would tell us something, for example, like if we wanted to look at a patient's cholesterol and work out have they had a 40% reduction from a target. And those are complex queries that you can build in EMIS-X analytics that you couldn't build in the population searches and reports. So better risk stratification, I think, and that allows us to better identify those people most in need and get those services to them.
Great, thanks, Nick. And using that last bit of your answer there as a segue into the next question, then the question is, how will the pathway that you described make services quicker and more efficient? Okay,
so speed and capacity issues are a major bugbear of general practice. How long it takes to get stuff done is a big problem, especially when you've got mounting numbers that need to be seen. There's more people currently with 2 long-term conditions than there is with 1 long-term condition, so we needed something that would help deal with people with multiple long-term conditions, and with that comes the complexity. So we need something that helps to reduce the complexity by cutting through the vast reams of data and delivering the relevant data to you to help you get to that decision that you need to make. So that's going to speed things up, that intelligent contextual support. We want to make the documentation quick. We want to take away tasks from clinicians that don't need a clinician to do it. And so by enabling healthcare assistants to support the data collection, we can remove tasks from clinicians like nurses or doctors or paramedics or pharmacists. And also we can facilitate the review to be done by people by nurses, doctors, paramedics more speedily by bringing all the information they need together with the guidance that's relevant and helping them to document it. So it's looking at all prongs of the approach about how we identify the patients more accurately and quickly by providing more meaningful displays of information, how we can then collect data from patients quickly and effectively and cost effectively, and how we can rapidly assess whether someone's control is good by using the computer-aided support to do that with the healthcare assistant, and then making clinical review of all those patients quicker by targeting the areas where people have health problems, so that those people who are less in need and are well controlled get that information quickly, and those people who have high levels of need, we have more time to deliver the complex care needs that they have.
Great, thanks very much, Nick. Great answer. Okay, sticking with you, Nick, I think. We've had a question here that says there is emerging information about long-term chronic illness caused by some COVID patients. Will EMIS and the functionality you described help manage this cohort of patients?
Okay, I think that that is a very new area, really. We are beginning to learn about, how COVID affects patients, and whatever a patient's COVID experience, whether their long-term conditions are well controlled, whether their comorbidity is well controlled, will affect their outcomes. So whilst we're not aiming at specifically providing measures to deal with specific sequelae of COVID, because we're still learning what that is, we know that whatever sequelae they have, if their long-term conditions are poorly controlled, they're going to have worse health outcomes. And this is not a static system. This is a system that evolves as NICE guidance moves. So does the information that is displayed. And as we learn more about the sequelae from COVID, we'll be able to provide information in the long-term condition manager. But we are not a creator of guidance. We are there trying to provide national guidance when it exists. And as there isn't current national guidance on that, we wouldn't currently be providing our own guidance.
Okay, that's great. Thanks, Nick. Yeah, certainly one to watch as the science behind all of that emerges, isn't it? So, okay, so we've got 9 minutes of our planned session left. Just a prompt again, if there's anyone sitting there waiting or thinking about asking a question, please do. We've got 2 outstanding now. Nick, this might be for you, or in fairness, you might push it back to me, and I'm okay with that. I wasn't planning on answering anything. Question: are all the things mentioned by Nick today going to be part of standard EMIS, or are these chargeable add-ons? And if so, what would the cost of it be? Nick, your face is saying that you're going to push it to me anyway. So I think it's fair to say that these will be additional cost items based on the development that Nick's described today. I'm not in a position to talk about the cost as such, but what I would recommend is after this session, we will be providing details for people to contact us for further queries. So if we do that, I will put our appropriate commercial colleagues in touch with the person that's asked that question. That's not a question of avoidance, it's just the fact that we're all clinicians, and Nick and I thankfully are in a privileged position not to get involved in pricing, so that's grand. But thank you for the question, really valid one. And the last question so far, gents, and Nick, it's to you again. The pathway that you described, and you've talked about many different professional groups being involved, I wonder if you could describe to us how you think it will enable greater collaboration across traditional boundaries. Really good question.
Well, I think that the data that we're collecting could come, that's going to inform the review, could come from anywhere in the health economy, really. It could be coming from in the community, the data points could be coming from the community entering that, and then the GP providing the review part of that. So really it's flexible. Some of the data points might come from anywhere in the community, in the health economy, that feeds into the EMIS record. The remaining data points would need to be completed because a review will only occur once we have all of the data. We won't try and give an assessment of control on a patient with only part of the information. That's common sense, really. That's a safety point. But it doesn't really matter where the data is coming from, provided it's being fed into the record through EMIS Clinical Services or any instance of EMIS. Then once we've got a complete data set, we can do that review stage.
Lovely, thanks, Nick. And I guess as well, to your earlier point around the various professions, I guess the flexibility that this provides to the various physical setups, economies, whether that be health, social care, or any variants, particularly as Mike described earlier in terms of the collaboration across the Herefordshire economy. I guess that could also go a long way to continuing what we've seen through COVID and the greater collaboration. So,
yeah, I mean, I've seen surgeries where a healthcare assistant is doing the collection, where a nurse is doing some of the collection, where some of the reviews are being done by pharmacists, where some of the reviews are being done by nurses, depending on the skills that you've got in your surgery and what's available to you in your setup, really.
Yeah, that's great. Thanks, Nick. And I guess to your point, Mike, that absolutely fits with what you've described. Any final remarks on that one?
Yeah, I think I just to reflect on the kind of some of the data stuff that we've been doing through EMIS Enterprise. So because we've had some success, obviously looking at that across general practice already, and joining those kind of that system up has been really positive. And when you talk about working with other colleagues, one of the challenges always is that data sharing element, and I don't mean necessarily across EMIS platform, but obviously just sharing kind of like the kind of looking at the data in a collective way to get the intelligence in a format that is actually useful. And I guess the final thought and final piece of advice on that is all the dashboards in the world, which we often end up creating, aren't always as useful as perhaps clinicians might consider. So actually really considering the measures of any project at the start before you move it forward, really important to nail those down, because you can end up measuring the wrong stuff. And I know that's really obvious, but actually the number of times we all do it, I think is something to really pause on and work collectively on to ensure that you get the right stuff to measure the right change.
Fantastic, Mike. Thank you. And a great point to end on. I think pause, work collaboratively, and make sure that you get the right outcome and the right change, I think is a perfect closing remark. So thank you very much. We don't have any other questions from the audience. We're 4 minutes short of our allotted time, which is not a bad position to be in. So I think on that basis, I'll call the session to an end. So I hope that certainly everyone that's joined today has enjoyed it, and you've been left at least with food for thought, as we all, you particularly, move towards hopefully the end of COVID and into the new normal. Just to confirm that following today's session, we will ensure that everyone receives a copy of the slide deck that you've seen today. And I think as well, James, you've offered to provide an additional slide just to show that technical journey that you so eloquently described earlier. So that's great. Thank you so much. We will also provide a link to the recording of the session today as well. We have managed to get through without having to move questions to after the session, but if there are any additional questions, we will provide contact details for you to contact us, and we will also provide a link to a case study produced by Taurus, which further describes what Mike has presented today. So it remains just to say thank you very much to Mike, to James and to Nick for their input today, also to colleagues in the background that you won't have seen because everything's gone technically brilliantly, but we have got colleagues working in the background to make this happen, so thank you very much to those as well. And finally, to all of you that have taken the time, either in your busy working day or possibly at the end of your very busy working day, to attend the session. Thank you very much. Hope you all have a good evening. Stay safe, and we'll call it an evening. Thank you very much. Goodbye.
Thanks, Ben.
Thank you. Bye-bye. Bye-bye.